Welcome to Bedtime Science. Did you know that every year, a small number of people recover from diseases that medicine considered untreatable, and no one can fully explain why? Tonight we look at the quiet, strange science behind unexplained medical recoveries. These are cases where the body did something that textbooks said it could not do, where tumors vanished, infections cleared, and organs repaired themselves without any known cause. In the next moments, we will gently move through how the medical world first began documenting these rare events, what the immune system does in the background that most people never notice, the careful records kept at healing sites like Lourdes, and what those records actually show, how belief, expectation, and the placebo effect physically change the body, what near-death experiences and ancient healing traditions reveal about the borders of recovery, how hormones, the vagus nerve, and the chemistry of human connection shape the immune system in ways researchers are still mapping, and where the limits of our explanations begin, and what those limits might mean. Before we begin, if you find comfort here tonight, consider subscribing to join our quiet community. And if you are still awake, you can leave a soft comment about what topic we should explore next. Now let's begin. In 1966, two researchers named Tilden Everson and Warren Cole published a small, careful book. It was called Spontaneous Regression of Cancer. The book gathered 176 cases from medical literature spanning several decades. Each case described a patient whose cancer had partially or completely disappeared without treatment that could account for the change. This was not a popular science book. It was dry, clinical, and cautious. Everson and Cole did not claim miracles. They did not suggest hidden cures. They simply noted that these events had been observed, documented, and verified by other physicians, and they admitted that no single explanation could account for all of them. That monograph became a quiet landmark. It was the first serious academic attempt to say, "This happens, and we do not understand it." The term they used was spontaneous regression. It means the partial or complete disappearance of a disease without any treatment, or with treatment considered inadequate to produce the observed result. The word spontaneous does not mean instant. Some regressions took weeks, others unfolded over months. The word simply means that no external medical cause could be identified. Before Everson and Cole, most physicians treated these cases as curiosities or mistakes. A tumor that vanished was assumed to have been misdiagnosed. A patient who recovered was assumed to have received treatment that was not properly recorded. The medical world did not have a framework for studying events that contradicted its predictions. Everson and Cole changed that. Not with drama, but with patience. They read thousands of case reports. They verified diagnoses. They excluded cases where the evidence was weak. What remained were 176 events that could not be easily dismissed. And the quiet question at the center of their book still has no complete answer. The rate of spontaneous regression in cancer is estimated at roughly 1 in every 60,000 to 100,000 cases. That number comes from scattered records across many decades, so the true rate may differ. Some researchers believe it is higher because many recoveries go unreported. A patient who gets better is less likely to return to the hospital than one who gets worse. This means that in a world where millions of people receive cancer diagnoses each year, a small but real number of them will experience something that their doctors cannot explain. not a treatment success, not a slow remission from therapy, a reversal that happens on its own, or seems to. The rarity is part of what makes these cases difficult to study. You cannot design a clinical trial around an event that happens unpredictably in a tiny fraction of patients with no known trigger. You can only collect the cases after they occur and look for patterns. And patterns do exist. Certain cancers regress more often than others. Certain circumstances appear again and again in the records, but the patterns are faint, like tracks left in sand before the tide comes in. Not all cancers regress at the same rate. Some types appear far more often in the medical literature on unexplained recovery. Renal cell carcinoma, a cancer of the kidney, is one of the most frequently reported. Neuroblastoma, a childhood cancer of nerve tissue, is another. Melanoma appears in the records as well, along with certain lymphomas and leukemias. No one knows exactly why these particular cancers show up more often. One possibility is that they tend to provoke stronger immune responses. The immune system may recognize the surface proteins on these tumor cells more easily than it recognizes other types. Another possibility is simply reporting bias. Doctors may be more likely to document regressions in cancers that are already known to occasionally regress. But there is a third possibility that researchers keep returning to. Some of these cancers may sit closer to a biological tipping point. Their growth may depend on conditions inside the body that can shift. A change in hormone levels, in inflammation, in blood supply, in immune signaling, and the balance tips. The tumor, which was growing, begins to shrink, not because something attacked it from outside, because something changed from within. One of the earliest patterns noticed in unexplained recoveries was the presence of fever. Everson and Cole noted it. Other researchers noticed it independently. In a number of documented regressions, the patient had experienced a high fever, often from an unrelated infection, shortly before the tumor began to shrink. This observation dates back centuries. In the 1700s and 1800s, scattered medical reports described patients whose cancers improved after bouts of malaria, erysipelas, or other severe infections. The connection was not understood, but it was noticed. Fever and recovery appeared together too often to ignore. What we now know is that fever is not just a symptom. It is an active immune event. When body temperature rises above its normal range, several things happen at the cellular level. White blood cells move faster. They become more active. Certain immune signaling molecules increase in concentration. The environment inside the body shifts in ways that make it harder for some types of cells, including some tumor cells, to survive. Fever is the body's oldest war drum, and sometimes when it sounds, things change in ways that medicine is still learning to read. In the 1890s, a surgeon in New York named William Coley began one of the strangest experiments in medical history. Coley had lost a young patient to bone cancer and was searching for anything that might help future cases. While reading old hospital records, he found something that stopped him. A patient with an inoperable sarcoma who had developed a severe skin infection after surgery. The infection nearly killed him, but when the infection cleared, the tumor was gone. Coley became convinced that the infection itself, or the immune response it triggered, had destroyed the cancer. He spent the next 4 decades testing that idea. He created a mixture of killed bacteria, later called Coley's toxins, and injected it into patients with inoperable tumors. The injections caused high fevers, chills, and intense immune activation. Some patients improved. Some experienced complete regressions that lasted years. Others did not respond at all. Coley's work was controversial during his lifetime and largely forgotten after his death. The rise of radiation therapy and chemotherapy pushed his methods to the margins of medicine. But decades later, when immunotherapy became one of the most promising fields in cancer research, scientists looked back at Coley's records with new eyes. He had been doing something real. He had been provoking the immune system into action. He just didn't have the language or the tools to explain what was happening inside the body when he did it. The immune system is not a single organ. It is a distributed network of cells, signals, and responses spread throughout the entire body. It operates in layers. The first layer, called innate immunity, responds quickly and broadly. It does not need to recognize a specific threat. It reacts to general signs of damage or invasion. The second layer, called adaptive immunity, is slower but far more precise. It learns. It remembers. It creates cells that are tailored to recognize specific molecular shapes on the surface of invaders or abnormal cells. Once it learns a target, it can remember that target for years, sometimes for a lifetime. Between these two layers, millions of immune cells circulate through the blood, the lymph nodes, and the tissues of every organ. They patrol. They communicate. They make decisions. And most of the time, they do all of this without any conscious awareness from the person whose body they protect. You are, right now, being defended by a system you cannot feel. Cells are moving through your bloodstream at this very moment, checking surfaces, exchanging chemical messages, deciding what belongs and what does not. It is one of the quietest and most complex operations in biology. Among the most important immune cells in the context of unexplained recovery are natural killer cells, usually called NK cells. These cells belong to the innate immune system. They do not need prior exposure to a threat. They do not need to be trained. They act on their own recognition. NK cells patrol the body looking for cells that display unusual surface markers. Healthy cells carry specific molecules on their outer membrane that signal self to the immune system. When a cell becomes infected by a virus, or when it begins to transform into a tumor cell, those surface signals can change. The cell may lose certain markers or display new ones. NK cells detect these changes. When they find a cell that has lost the normal self markers, they attach to it and release small packets of toxic proteins called perforin and granzymes. Perforin creates holes in the target cell's membrane. Granzymes enter through those holes and trigger a process called apoptosis, which is programmed cell death. The whole interaction takes minutes. The target cell dies quietly. The NK cell moves on. In studies of patients who experienced unexplained tumor regression, researchers have sometimes found elevated NK cell activity. The immune system had, for reasons not fully understood, increased its surveillance. And in those patients, the surveillance found its target. Cytotoxic T lymphocytes, often called CTLs or killer T cells, work differently from NK cells. They belong to the adaptive immune system. They need to be activated. They need to be shown a target. But once activated, they are precise and relentless. Here is how it works. When a cell inside the body becomes abnormal, whether from viral infection or cancerous mutation, it may display fragments of abnormal proteins on its surface. These fragments sit inside small molecular frames called MHC class I molecules. They are, in effect, tiny flags that say, something has changed inside this cell. Dendritic cells, which act as scouts for the immune system, collect these fragments and carry them to the lymph nodes. There, they present the fragments to T cells. If a T cell has a receptor that matches the fragment, it becomes activated. It begins to multiply rapidly, producing an army of clones, all programmed to recognize and destroy cells displaying that specific molecular flag. These activated CTLs then travel through the bloodstream and into the tissues, hunting for cells that carry the target. When they find one, they kill it using the same perforin and granzyme mechanism as NK cells. In some cases of unexplained recovery, biopsies taken from shrinking tumors have shown dense infiltration by T cells. The immune system had recognized the tumor as a threat, mounted a targeted response, and begun dismantling it, cell by cell. The immune system does not always recognize tumors. In fact, one of the central challenges in cancer biology is understanding why the immune system so often fails to detect cancerous cells. Tumors have evolved numerous strategies to hide. Some tumor cells downregulate the surface molecules that immune cells use for recognition. Others release chemical signals that suppress immune activity in the tissue surrounding the tumor. This creates what researchers call an immunosuppressive microenvironment, a small zone around the tumor where immune cells are present but functionally silenced. Some tumors even recruit immune cells to help them. Certain types of macrophages, called tumor-associated macrophages, can be reprogrammed by the tumor to promote blood vessel growth, suppress inflammation, and support tumor expansion. The immune system in these cases is not absent, it is co-opted. This is what makes unexplained regression so puzzling. Something breaks through the tumor's defenses. Something shifts the balance. The immune cells that were suppressed become active again. The ones that were helping the tumor switch sides. What triggers that shift remains one of the open questions in cancer immunology. But the fact that it happens, even rarely, tells us that the body carries within it the capacity to reverse a process that seemed irreversible. Modern immunotherapy is, in many ways, an attempt to do deliberately what unexplained recoveries do on their own. Checkpoint inhibitors, one of the most successful classes of cancer immunotherapy drugs, work by removing the molecular brakes that tumors place on T cells. Here is the mechanism. T cells carry a receptor on their surface called PD-1. When this receptor binds to a molecule called PD-L1 on the surface of another cell, the T cell receives a stand-down signal. It stops attacking. Many tumor cells exploit this by displaying large amounts of PD-L1. They wear a molecular disguise that tells the immune system to leave them alone. Checkpoint inhibitor drugs block the PD-1-PD-L1 interaction. With the brake removed, T cells can recognize the tumor and attack. The results have been dramatic in some cancers. Melanoma, lung cancer, and certain lymphomas have shown strong responses. But not all patients respond, and researchers are still working to understand why. What is worth noting is that the principle behind these drugs came, in part, from studying the rare cases where the body accomplished the same thing without help. The immune system already had the tools. It just needed the brakes released. The body's own pharmacy, it turns out, has been stocked for a long time. We are only now learning to read the labels. Inflammation is one of the most misunderstood processes in the body. Most people associate it with pain, redness, and swelling. Those are the visible signs of acute inflammation, which is a short-term immune response to injury or infection. But inflammation also operates at a chronic, low-level state that can persist for months or years without obvious symptoms. Chronic inflammation plays a complicated role in cancer. On one hand, prolonged inflammation can damage DNA, promote cell mutations, and create conditions that encourage tumor growth. Many cancers arise in tissues that have been inflamed for long periods. The liver after chronic hepatitis, the colon in inflammatory bowel disease, the lungs after years of exposure to irritants. On the other hand, acute inflammatory bursts can sometimes activate the immune system in ways that help it recognize and fight tumors. This is what Coley was accidentally triggering with his bacterial injections. The infection caused a spike of inflammation. That spike activated immune cells, and in some patients, those activated immune cells attacked the tumor along with the bacteria. The difference between inflammation that feeds cancer and inflammation that fights it appears to depend on timing, intensity, and the specific immune cells involved. A short, controlled burst may help. A long, low simmer may harm. The body walks a narrow line every day between protection and damage, and both use the same tools. The medical literature contains a particular category of unexplained recovery that draws special attention. Cases verified by institutional review. The most well-known institution for this is the Lourdes Medical Bureau, known by its French acronym CMIL, Comité Médical International de Lourdes. Lourdes is a site in southwestern France where, since 1858, millions of people have visited seeking healing. The Catholic Church established a medical bureau to investigate reported cures. What makes the CMIL unusual is its process. It does not begin with faith. It begins with medical records. When a person claims to have been healed at Lourdes, the CMIL requests their complete medical file. It reviews diagnostic imaging, biopsy results, blood work, and physician reports. It requires that the original diagnosis be confirmed by multiple doctors. It requires that the recovery be complete, lasting, and unexplainable by current medical science. The committee includes physicians of various specialities and, notably, of various faiths. Non-Catholic and non-religious doctors have served on the panel. The goal is medical verification, not religious validation. Since 1858, out of approximately 7,000 reported cures, only 70 have been formally recognized by the CMIL as medically inexplicable. That ratio, 70 out of 7,000, tells you something about the rigor of the process. These are not casual claims. They are cases where extensive documentation supports the conclusion that something happened that the medical committee could not explain. One of the most carefully documented cases from Lourdes involves a man named Vittorio Micheli. In 1962, Micheli was diagnosed with a large sarcoma, a cancerous tumor of the left hip. The tumor had destroyed a significant portion of the bone. X-rays showed the pelvis dissolving. The femur had disconnected from the hip socket entirely due to bone destruction. Micheli visited Lourdes and bathed in the spring water. Over the following months, his tumor began to shrink. Eventually, it disappeared. But what happened next is what drew the attention of the medical committee most closely. The bone began to regrow. The hip joint reconstructed itself. New bone formed where the tumor had destroyed the old structure. the femur reattached to the pelvis in a functional joint. Bone regeneration on this scale is not supposed to happen in adults. The body can heal fractures, yes, but rebuilding an entire joint that was consumed by cancer, without surgical intervention, without bone grafts, without any medical procedure at all. The CMIL panel reviewed the case for years. Multiple radiologists examined the imaging. The before and after X-rays showed a sequence that no standard medical model could produce. Micheli's case was formally recognized in 1976. The medical files remain available for review. It sits in the records, quiet, verified, and unexplained. Another case from the CMIL files involves Delizia Ciroli, a young girl from Sicily. In 1976, at the age of 12, she was diagnosed with Ewing's sarcoma of the right knee. This is an aggressive bone cancer. The prognosis was poor. Her family was told that amputation would be necessary, and even then, survival was uncertain. Her family took her to Lourdes instead. After returning home, her condition began to change. The swelling in her knee decreased. Over the following months, imaging showed the tumor shrinking. It eventually disappeared entirely. The bone healed. She was examined repeatedly over the following years. The cancer did not return. She went on to live a full, healthy life. The CMIL reviewed her case over a period of more than a decade. Her original diagnosis was confirmed by multiple pathologists. The regression was documented by serial imaging. No medical treatment had been given that could account for the result. Her case was formally recognized in 1989. What makes cases like Ciroli's useful to researchers is not the setting, it is the documentation. The CMIL functions in practice like a slow and extremely cautious case study archive. The diagnoses are verified. The timelines are recorded. The recoveries are confirmed over years, not days. Whether one attributes these recoveries to a spiritual force or an unknown biological mechanism, the medical records remain the same. A third case worth mentioning involves Jean-Pierre Bailly, a French man diagnosed with multiple sclerosis. By 1987, his condition had progressed to the point where he was almost entirely paralyzed. He had lost the ability to walk, was confined to a wheelchair, and required assistance with basic daily functions. His neurological decline had been documented over years. He visited Lourdes in October 1987. During the visit, he reported a sudden return of sensation and movement. Within hours, he was walking. Neurological examination after his return home showed a dramatic reversal of his symptoms. The CMIL investigation of Bailey's case took over 12 years. Neurologists reviewed his complete medical history. The committee wanted to confirm that the original diagnosis was correct, that the disease had been as severe as reported, and that the recovery was genuine and lasting. In 1999, the case was formally recognized. Bailey's recovery from advanced multiple sclerosis remains one of the more recent additions to the CMIL archive. Multiple sclerosis is an autoimmune condition in which the immune system attacks the myelin sheath surrounding nerve fibers. Recovery from advanced MS, without treatment, contradicts the expected trajectory of the disease. The myelin damage is typically considered permanent at advanced stages. And yet the records show what they show. Not all documented unexplained recoveries come from religious sites. Hospitals around the world have recorded cases that follow a similar pattern. confirmed diagnosis, no adequate treatment, and measurable recovery. A recurring feature in many of these cases is that the patient's emotional or psychological state changed before the physical recovery began. This does not mean the patient thought themselves well. It means that researchers have noticed in the records a pattern of psychological shifts, a reduction in chronic stress, a change in outlook, an experience of deep social connection, or a resolution of long-standing emotional conflict. These observations are difficult to study with controlled methods. You cannot randomly assign people to have life-changing emotional experiences. But the pattern appears often enough that researchers in the field of psychoneuroimmunology, the study of how the mind affects the immune system through the nervous system, consider it a legitimate area of investigation. The body and the mind do not operate in separate compartments. They share chemical messengers. They share neural pathways. A shift in one system sends ripples through the other. What those ripples can do, in rare cases, appears to exceed what current models predict. The placebo effect is one of the most reliably documented phenomena in medicine. It occurs when a patient receives a treatment that has no active therapeutic ingredient, a sugar pill, a saline injection, or even a sham surgical procedure, and yet experiences measurable improvement in their condition. This is not imaginary improvement. The placebo effect produces real physiological changes. Brain imaging studies have shown that when a patient believes they are receiving pain medication, the brain releases endorphins, the body's own pain-reducing molecules. The pain decreases. The chemistry is real. In studies of Parkinson's disease, patients who received placebo injections, believing they were receiving medication, showed increased dopamine release in the brain. Dopamine is the exact neurotransmitter that Parkinson's disease depletes. The belief in treatment triggered the brain to produce more of the substance it was lacking. The placebo effect is not a trick. It is not the absence of treatment. It is a measurable biological response to expectation, context, and the rituals of care. And it raises a question that researchers have been circling for decades. If belief can trigger the release of specific neurotransmitters and immune molecules, what are the upper limits of that process? Where does the placebo effect end? No one has a confident answer yet. In 2002, a surgeon named Bruce mostly published the results of a trial that would become one of the most discussed studies in placebo research. The study involved patients with osteoarthritis of the knee. All patients were told they would receive arthroscopic surgery, a common procedure where small instruments are inserted into the knee joint to clean out damaged tissue. The patients were divided into 3 groups. One group received the standard surgical procedure, another received a simpler version, and the third group received sham surgery. In the sham condition, the surgeon made small incisions in the skin around the knee, manipulated the leg as if performing surgery, and then closed the incisions. No instruments entered the joint. No tissue was cleaned or removed. The patients did not know which group they were in. They all woke from anesthesia with bandaged knees and went through the same recovery process. 2 years later, all 3 groups showed the same level of improvement. The patients who received sham surgery did just as well as those who received real surgery. Their pain decreased. Their mobility improved. Their knees functioned better. The study suggested that the benefit many patients experienced from knee arthroscopy was coming not from the procedure itself, but from the context surrounding it. The hospital, the surgeon, the anesthesia, the expectation of healing. The body had responded to the story of surgery, even when the surgery did not actually happen. The nocebo effect is the placebo's opposite, and in some ways, it is more unsettling. While the placebo effect describes improvement from an inert treatment, the nocebo effect describes harm. If a patient is told that a medication may cause headaches, they are more likely to experience headaches, even if the medication contains no active ingredient. If a doctor warns that a procedure will be painful, the patient often reports more pain than patients who receive the same procedure with neutral framing. In drug trials, patients receiving sugar pills report the side effects they were warned about at rates that sometimes approach those of the actual drug group. This is not malingering. These are genuine physiological responses. The body creates the very symptoms the mind was told to expect. One of the most striking examples comes from a case report published in 2007. A young man attempted suicide by swallowing an entire bottle of pills he believed were antidepressants. He was enrolled in a clinical trial and had been taking capsules daily. After swallowing the pills, his blood pressure dropped, his heart rate became unstable, and he was rushed to the hospital in a serious condition. When the hospital contacted the trial administrators, they were told that the man was in the placebo group. He had swallowed a bottle of sugar pills, but his body responded as if the overdose were real. Once he was told the pills were inert, his vital signs stabilized within 15 minutes. The mind, it seems, can write prescriptions the body fills without question. Expectation does not act alone. The placebo effect is shaped by context. The environment, the relationship with the practitioner, the color of the pill, the size of the needle, the confidence in the voice of the person providing treatment. Studies have shown that larger placebo pills produce stronger effects than smaller ones. That injected placebos work better than oral ones. That placebos labeled with a well-known brand name outperform identical placebos with generic labels. The color of the pill matters. Red and orange placebos tend to act as stimulants. Blue placebos tend to act as sedatives. These patterns suggest that the placebo effect is not just about belief in the abstract. It is about embodied cues. The brain reads the environment, the ritual, the appearance of the treatment, and uses that information to calibrate its response. In cultures where injections are the standard form of medical treatment, injections produce stronger placebo effects. In cultures where herbal remedies carry authority, herbal placebos may outperform pharmaceutical ones. The body listens to context. It pays attention to what it has been taught to expect, and it adjusts its chemistry accordingly. Open-label placebos represent one of the most surprising findings in placebo research. These are placebos given to patients who are told, explicitly, that the pill contains no active ingredient. The patient knows it is a sugar pill. They take it anyway, and in a number of studies, they still improve. In a 2010 study on irritable bowel syndrome, patients were told, these pills are made of an inert substance, like sugar pills, that have been shown in clinical studies to produce significant improvement through mind-body self-healing processes. The patients who took the open-label placebos showed measurably greater improvement than those who received no treatment. This challenges the common assumption that placebos only work through deception. Something deeper appears to be operating. The ritual of taking a pill, the act of doing something about one's condition, the engagement with a caring practitioner. These elements may carry therapeutic weight independent of whether the patient believes in a hidden active ingredient. The implication is that the healing context itself, separate from any drug or procedure, has biological effects. The body responds to care, to routine, to the structured act of treatment. It is a quiet finding, but it reaches far. The brain does not experience pain directly from the site of injury. Pain is constructed. Signals travel from the injured area through nerves to the spinal cord and then to the brain. But the brain does not simply receive these signals passively. It interprets them. It compares them with expectations, memories, and emotional states. Then it produces the experience of pain. This means pain can be modulated at the level of the brain. A soldier wounded in battle may feel little pain during the fight because the brain suppresses pain signals in life-threatening situations, prioritizing survival over comfort. After the danger passes, the pain arrives in full. Conversely, a person in a state of anxiety may feel more pain from a minor injury than a calm person with a severe one. The emotional context shapes the signal. The brain turns the volume up or down based on what it expects and what it feels. This is not a metaphor. The descending pain modulation system is a well-mapped set of neural pathways running from the brainstem to the spinal cord. When these pathways are active, they suppress incoming pain signals before they reach conscious awareness. Expectation, emotion, and context all feed into this system. And in the placebo effect, they activate it in measurable, reproducible ways. Endorphins are perhaps the best-known molecules involved in placebo-driven pain relief. These are peptides produced by the brain that bind to opioid receptors, the same receptors targeted by drugs like morphine. When endorphins are released, pain decreases and a sense of well-being increases. In a landmark study, researchers gave patients a placebo painkiller and observed measurable pain relief. Then they gave the same patients naloxone, a drug that blocks opioid receptors. The pain relief disappeared. This proved that the placebo effect in this case was operating through the endorphin system. The brain was releasing real molecules in response to the expectation of treatment. But endorphins are not the only molecules involved. Placebo responses in Parkinson's disease involve dopamine. Placebo responses in anxiety involve changes in serotonin and GABA activity. The specific molecular pathway activated by the placebo effect appears to depend on the condition being treated and the expectation being created. The brain does not have a single placebo switch. It has many, each one connected to a different chemical system, each one activated by a different kind of expectation. The pharmacy inside your skull does not close at night. It fills orders around the clock, based on signals you may not even know you are sending. The relationship between the mind and the immune system runs through the nervous system and the endocrine system. The field that studies these connections is called psychoneuroimmunology. The name itself maps the pathway. Psycho, mind; neuro, nervous system; immunology, immune system. Research in this field has established that the brain can influence immune function through at least two major routes. The first is the hypothalamic pituitary adrenal axis, usually called the HPA axis. When the brain perceives stress, the hypothalamus signals the pituitary gland, which signals the adrenal glands to release cortisol. Cortisol is a powerful anti-inflammatory hormone. In short bursts, it helps the body manage acute stress. In prolonged exposure, it suppresses immune function. The second route is the autonomic nervous system, which connects the brain directly to immune organs such as the spleen, the thymus, and the lymph nodes. Nerve fibers reach into these organs and release neurotransmitters that affect immune cell behavior. This means the brain is not merely aware of the immune system, it is wired into it. When your mental state changes, your immune state can change with it. Not always, not reliably, but measurably and through identified biological pathways. The mind and the immune system speak to each other, not in words, in molecules. Cortisol, the stress hormone, deserves careful attention in any discussion of unexplained recovery. Under normal conditions, cortisol follows a predictable daily cycle. It peaks in the morning, helping the body wake up, and gradually declines through the day. This rhythm, called the diurnal cortisol slope, is a marker of healthy stress regulation. In people under chronic stress, whether from illness, trauma, social isolation, or unresolved conflict, this rhythm can flatten. Cortisol levels remain elevated throughout the day, never fully returning to baseline. The body stays in a state of low-grade emergency. Chronically elevated cortisol suppresses several components of the immune system. It reduces the number of circulating lymphocytes. It impairs the function of NK cells. It blunts the inflammatory response that is needed to identify and destroy abnormal cells. In cancer patients, studies have found that a flat cortisol slope is associated with faster disease progression and shorter survival. Patients with a more normal cortisol rhythm tend to have better outcomes. This does not mean that stress causes cancer. The relationship is not that simple, but it does mean that chronic stress creates a biochemical environment in which the immune system is less able to do its work. And conversely, when chronic stress resolves, the immune system may regain some of the capacity it had lost. The vagus nerve is the longest cranial nerve in the body. It begins at the brainstem and branches downward through the neck, the chest, and the abdomen, connecting to the heart, the lungs, the stomach, the intestines, the spleen, and the liver. It serves as a major communication highway between the brain and the body. And one of its most important functions is the regulation of inflammation. In 2000, a neuroscientist named Kevin Tracy discovered something he called the cholinergic anti-inflammatory pathway. He found that stimulating the vagus nerve caused the release of acetylcholine at the nerve endings in the spleen. This acetylcholine bound to receptors on macrophages, a type of immune cell, and reduced their production of tumor necrosis factor, a key inflammatory molecule. In other words, the brain could turn down inflammation by sending a signal through a single nerve. This discovery opened a new field of research, sometimes called bioelectronic medicine. Researchers have since developed implantable devices that stimulate the vagus nerve to treat inflammatory conditions like rheumatoid arthritis. Early trials have shown measurable reductions in joint swelling and pain. The relevance to unexplained recovery is this: any process that activates the vagus nerve, deep breathing, meditation, social bonding, certain emotional states, may, through this pathway, shift the immune system's behavior, not as a cure, but as a nudge. A quiet signal, traveling along a single nerve, adjusting the body's inflammatory response from the inside. Oxytocin is most commonly known as the bonding hormone. It is released during physical touch, social connection, breastfeeding, and intimate contact. But oxytocin also has immunological effects that are less widely discussed. Research has shown that oxytocin reduces cortisol levels. It promotes a sense of safety and calm, which shifts the nervous system away from the stress response and toward a state of rest and repair. This shift has downstream effects on the immune system because reduced cortisol means reduced immune suppression. Some studies have also found that oxytocin can directly influence the behavior of certain immune cells. It appears to modulate inflammatory cytokine production and may promote wound healing at the tissue level. In the context of unexplained recovery, this is relevant because many case reports describe recoveries that followed a significant change in social circumstances. Reuniting with loved ones, resolving a long conflict, receiving unexpected support, or experiencing a deep sense of being cared for. These events flood the brain with oxytocin and related neurochemicals. They lower cortisol. They activate the vagus nerve. They shift the body from a state of defensive vigilance to one of restoration. No one is claiming that a hug can cure cancer, but the biochemistry of human connection feeds directly into the systems that regulate immune function. And that connection is not minor, it is wired deep. GABA, or gamma-aminobutyric acid, is the brain's primary inhibitory neurotransmitter. Its job is to slow things down. When GABA binds to its receptors, it reduces the firing rate of neurons. This creates a calming effect throughout the nervous system. Medications for anxiety and insomnia, such as benzodiazepines, work by enhancing the effect of GABA. But the body also regulates GABA naturally through sleep, relaxation, meditation, and other restorative states. What is less well known is that GABA receptors exist outside the brain. They are found on immune cells, including T lymphocytes and macrophages. Research has shown that GABA can modulate immune cell activity, influencing inflammation and immune regulation. In states of deep relaxation, when GABA levels are high and the nervous system is quiet, the immune system appears to enter a different operational mode. Not shut down, recalibrated. The balance between pro-inflammatory and anti-inflammatory signals shifts. Cell repair processes increase. The body redirects its resources from alert response to maintenance and restoration. This is one reason that chronic insomnia and chronic anxiety are associated with impaired immune function. The brain, in a constant state of activation, never fully shifts into the restoration mode that GABA facilitates. Sleep, calm, and safety are not luxuries. They are biological conditions that the immune system depends on to function at its best. Serotonin is usually associated with mood. Low serotonin is linked to depression, and most common antidepressants work by increasing serotonin availability in the brain. But here is something that surprises many people. Roughly 90% of the body's serotonin is not in the brain. It is in the gut. Serotonin in the gut helps regulate digestion, intestinal movement, and the gut-brain communication axis. But it also plays a role in immune function. Serotonin receptors are found on various immune cells, including T cells, macrophages, and dendritic cells. Serotonin can influence how these cells respond to threats, how they communicate with each other, and how inflammation is regulated. The gut, in this sense, is not just a digestive organ. It is an immune organ and a neuroendocrine organ. It contains its own nervous system, the enteric nervous system, its own serotonin production, and a vast population of immune cells. In fact, the gut-associated lymphoid tissue is one of the largest immune structures in the body. This means that processes affecting gut health, including stress, diet, microbial composition, and emotional states, can influence immune function through serotonin and other shared signaling molecules. The body is more interconnected than most people realize. A change in one system sends signals through pathways that reach into systems that seem, at first, unrelated. Meditation has been studied for its effects on the immune system, and the results, while modest, point in a consistent direction. Several controlled trials have found that regular meditation practice is associated with reduced markers of inflammation, improved immune cell function, and changes in gene expression related to immune regulation. One of the most cited studies was conducted by Richard Davidson and John Kabat-Zinn. Participants who completed an 8-week mindfulness meditation program showed greater antibody response to influenza vaccination compared to a control group. Their immune systems responded more vigorously to the vaccine. Other studies have found that meditation practitioners show lower levels of C-reactive protein, a marker of systemic inflammation, and changes in the expression of genes related to the NF-κB inflammatory pathway. These effects are not large enough to suggest that meditation could replace medical treatment, but they are consistent enough to suggest that mental states affect immune function through real biological pathways. And they connect back to the mechanisms we have already discussed: vagus nerve activation, cortisol reduction, GABA enhancement, and shifts in the balance between sympathetic fight or flight and parasympathetic rest and restore nervous system activity. The body does not separate thoughts from tissues. They share the same chemistry. They travel the same nerves. There is a phenomenon in medical research called regression to the mean. It is important to understand because it accounts for some recoveries that appear unexplained but have a statistical rather than biological explanation. Here is how it works. When a person is diagnosed with a serious illness, they are often diagnosed at a point when their symptoms are at their worst. That is what brought them to the doctor. But biological measurements fluctuate naturally. Blood pressure rises and falls. Tumor markers go up and down. Pain increases and decreases. If a measurement is taken at its peak, the next measurement is statistically likely to be lower, simply because peaks do not last forever. This can create the appearance of improvement even if nothing has actually changed in the underlying disease. Regression to the mean does not explain all unexplained recoveries. It does not explain tumors that vanish entirely or bones that regrow. But it does explain some of the less dramatic cases where patients report feeling better after visiting a healer or trying an alternative treatment. They may have been measured at their worst, and the natural fluctuation made the next measurement look like improvement. Good researchers know to account for this. It is one of the reasons that controlled trials use comparison groups and repeated measurements. But in individual case reports, regression to the mean is always a possibility that must be considered. Not every recovery is a mystery. Some are statistics. Misdiagnosis is another factor that must be acknowledged honestly. In a review of autopsy studies, researchers have found that the misdiagnosis rate in modern medicine, while declining, is not zero. Some estimates suggest that clinically significant diagnostic errors occur in roughly 10 to 15% of cases, depending on the condition and the study. In the context of unexplained recovery, this means that some patients who appear to recover from a serious disease may never have had that disease in the first place. A lesion read as malignant on one scan may be reclassified as benign on further review. A set of symptoms interpreted as one condition may later fit a different, less serious diagnosis. This is not a criticism of medicine. Diagnosis is genuinely difficult. The human body is complex, imaging has limitations, and pathology slides can be ambiguous. Honest uncertainty is part of the process. But it means that when we evaluate cases of unexplained recovery, we must hold space for the possibility that the original diagnosis was wrong. The most rigorous case studies, like those in the CMIL archive, address this by requiring multiple independent confirmations of the diagnosis. But not all reported recoveries have been verified to that standard. Some miracles may be errors, not all, but some, and acknowledging that does not diminish the cases that survive scrutiny, it strengthens them. Glioblastoma is one of the most aggressive cancers known to medicine. It arises in the brain, grows rapidly, and resists most treatments. The median survival time after diagnosis is approximately 14 to 16 months, even with surgery, radiation, and chemotherapy combined. 5-year survival rates remain in the low single digits. And yet, there are documented cases of long-term survival and even apparent cure. A small number of glioblastoma patients have lived for 10 years or more after diagnosis. An even smaller number have shown complete regression of their tumors. Researchers studying these rare survivors have found some distinctive features. In several cases, the tumor tissue showed very high levels of immune cell infiltration, particularly T cells. The immune system had mounted an unusually vigorous response against the tumor. Genetic analysis revealed that some of these tumors had a higher than average mutation rate, which may have made them more visible to the immune system. Other long-term survivors had tumors with a specific molecular profile, including IDH mutations and MGMT promoter methylation, that are associated with better treatment response. But even accounting for these factors, some cases remain difficult to explain. Glioblastoma is a cancer that should not go away. When it does, it draws the attention of every researcher in the field. These cases are rare. They are not a basis for hope in the conventional sense, but they are a basis for continued investigation. The body replaces itself continuously. Every cell has a lifespan, and when a cell reaches the end of its life, it is dismantled and replaced. The lining of the stomach replaces itself every few days. Red blood cells last about 4 months. The outer layer of skin turns over in roughly 2 to 3 weeks. This constant renewal is not random. It is governed by tightly regulated systems of cell division, cell death, and quality control. Stem cells in various tissues produce new cells. Old or damaged cells receive signals to undergo apoptosis, programmed self-destruction, and the immune system patrols for cells that have escaped these controls. In theory, this means the body has a built-in mechanism for clearing abnormal cells. If a cell mutates, it may be detected and eliminated before it can establish a tumor. This process, called immune surveillance, operates silently every day. Most people will develop abnormal cells at some point in their lives. Most of those cells will be destroyed by the immune system before they cause any harm. The fact that cancer develops at all means that some cells escape surveillance. And the fact that cancer sometimes regresses means that surveillance can, on occasion, catch up. The body is always rebuilding itself, even now, even while you rest. There are scattered historical accounts of unexplained recovery that predate modern medicine by thousands of years. The ancient Greeks recorded healings at the temple of Asclepius in Epidaurus. Stone tablets found at the site describe patients who arrived with tumors, blindness, paralysis, and other conditions, and who left the temple reporting recovery. The process at Epidaurus involved a practice called incubation. Patients would sleep in the temple overnight, often after rituals of fasting, bathing, and prayer. During the night, they believed the god Asclepius would visit them in their dreams and heal them. The tablets describe these dream encounters in specific detail. Modern historians and psychologists have debated what was happening at Epidaurus. Some suggest the healings were psychosomatic, driven by deep belief, intense ritual, and the social expectations of the temple environment. Others suggest that the sleep-based rituals may have induced states similar to hypnosis or deep relaxation, which could have activated some of the same physiological pathways we discussed earlier: vagus nerve stimulation, cortisol reduction, and immune modulation. What is clear is that the human practice of creating structured healing environments is very old. The belief that the mind and body can be shifted by ritual, context, and expectation is not a modern discovery. It is one of the oldest observations in human culture. The stone tablets at Epidaurus are worn by time, but the questions they raise have not aged at all. Near-death experiences occupy a strange position in medical literature. They are reported by a meaningful percentage of people who survive cardiac arrest or other life-threatening events. The features are consistent across cultures: a sense of leaving the body, moving through a dark space, encountering a light, feeling profound peace, and sometimes meeting deceased relatives or encountering a presence. From a neurological perspective, several explanations have been proposed. Oxygen deprivation in the brain can trigger hallucinations. Surges of electrical activity in the dying brain may produce vivid experiences. The release of endorphins during extreme stress could account for the feeling of peace. DMT, a naturally occurring psychedelic compound, has been detected in small amounts in the brain and may play a role. But what draws the attention of researchers studying unexplained recovery is not the experience itself. It is what sometimes happens afterward. A number of case reports describe patients whose health improved in unexpected ways following a near-death experience. The most well-known account is that of Anita Morjani, who was admitted to a hospital in Hong Kong in 2006 with end-stage Hodgkin's lymphoma. Her organs were failing. Tumors the size of lemons filled her lymphatic system. She entered a coma. During the coma, she reported a vivid near-death experience. When she regained consciousness, her condition began to improve. Within weeks, the tumors had shrunk dramatically. Within months, no cancer could be detected. Her case has been documented by her oncology team and has drawn both medical interest and skepticism. No standard model explains the speed or completeness of her recovery. It sits at the edge of what medicine can account for, a place where the records are clear, but the explanation is not. Eben Alexander's case is different in kind, but similarly unsettling to conventional models. Alexander is a neurosurgeon who, in 2008, contracted a rare form of bacterial meningitis that shut down his neocortex. Brain scans during his illness showed almost no cortical activity. By all standard measures, the parts of the brain responsible for conscious experience were offline. And yet, Alexander reported an extraordinarily vivid and structured experience during the period when his cortex was inactive. He described it in detail after his recovery, and it shared many features with classic near-death accounts. A sense of expanded reality, encounters with beings, a feeling of profound knowledge. The medical puzzle here is not the experience itself, though that is debated. The puzzle is the recovery. Bacterial meningitis of the severity Alexander experienced carries a mortality rate above 90%. Those who survive often have lasting neurological damage. Alexander recovered fully, returning to his medical practice and showing no significant cognitive impairment. His case raises questions about the brain's resilience, about what happens in neural tissue during periods of apparent inactivity, about whether recovery processes can operate at levels that current imaging cannot capture. These questions do not have settled answers. They are open, and they sit alongside the other open questions in this long, quiet catalog of things the body has done that we did not expect. Hypnosis, once dismissed as stage trickery, has gained a more respected position in medical research over the past several decades. Clinical hypnosis, as practiced in hospitals, involves guiding a patient into a focused, relaxed state where they become more responsive to specific suggestions. What is relevant here is that hypnotic suggestion can produce measurable physiological changes. Under hypnosis, patients have demonstrated reduced pain perception, altered blood flow to specific body regions, changes in skin temperature, and modifications in immune cell activity. In one notable study, hypnotic suggestion was used to modulate the immune response to a tuberculin skin test. Participants who were given hypnotic suggestions to suppress their immune response showed smaller skin reactions, indicating reduced local immune activity. Those given suggestions to enhance their response showed larger reactions. This is not a major clinical finding. The effects were modest, but the principle is worth noting. Directed mental focus in a state of deep relaxation produced a measurable change in how the immune system responded at a specific location in the body. The mechanism likely involves the same pathways we have already traced: hypothalamic regulation, autonomic nervous system shifts, changes in cortisol and catecholamine release. Hypnosis may simply be a particularly effective way to access these pathways intentionally. The border between mind and body is not a wall, it is a membrane, and under certain conditions, signals pass through it more easily than we thought. Social isolation has been identified as an independent risk factor for mortality. Studies spanning multiple decades and countries have consistently found that people with fewer social connections have higher rates of illness and shorter lifespans, even after controlling for variables like income, smoking, diet, and exercise. The biologist John Cacioppo spent much of his career studying the physiological effects of loneliness. His research showed that loneliness, the subjective experience of social disconnection, activates the stress response. Cortisol levels rise, inflammatory markers increase, sleep quality declines, gene expression shifts toward a profile associated with chronic inflammation and suppressed antiviral defense. This is not a correlation without mechanism. The biological pathways have been mapped. Loneliness changes the brain's interpretation of the social environment, shifting it toward threat detection and vigilance. This activates the sympathetic nervous system, which in turn affects immune regulation, cardiovascular function, and cellular repair. Conversely, social connection, the feeling of being seen, known, and supported, activates the parasympathetic system. It promotes oxytocin release, vagal tone, and the restoration-oriented processes we have discussed. In the context of unexplained recovery, this is relevant because the patients who recover are not isolated data points. They live in social worlds, and the quality of those worlds, the warmth or coldness of the connections around them, feeds directly into the biological systems that govern healing. No cell in the body is unaware that you are alone or that you are not. Emotional disclosure, the act of expressing difficult or suppressed emotions, has been studied for its effects on health since the 1980s. The psychologist James Pennebaker conducted a series of experiments in which participants wrote about traumatic experiences for 15 to 20 minutes a day over several days. The results were consistent across multiple studies. Participants who wrote about their deepest thoughts and feelings related to trauma showed improved immune function, measured by T-cell proliferation and antibody response to hepatitis B vaccination, fewer visits to the doctor, and improved psychological well-being, compared to control groups who wrote about neutral topics. Pennebaker's explanation centered on the concept of inhibition. Suppressing emotional experience requires physiological effort. The body maintains a state of low-level autonomic arousal when holding back strong emotions. This chronic arousal taxes the immune system over time. When the emotion is expressed, the arousal decreases, and immune resources become available for other functions. This finding connects to the pattern observed in some unexplained recoveries, where patients describe a moment of emotional release, a catharsis, or a shift in how they relate to their illness, shortly before their condition begins to improve. The body keeps score, and sometimes when the held weight is finally set down, the body recalculates what it can do. The concept of secondary gain is well known in psychology. It refers to the indirect benefits a person may receive from being ill: attention, care, relief from responsibilities, or a way to maintain important relationships. These benefits are usually unconscious. The person does not choose to be ill, but the illness, once present, may serve a function in their psychological or social life. In some therapeutic frameworks, the resolution of the psychological need that the illness was fulfilling can precede physical improvement. This is not the same as saying the illness was all in the head. It is saying that the body, in its constant negotiation between competing demands, may allocate resources differently when the psychological landscape changes. This idea remains controversial. It risks blaming patients for their own illness, which is both unkind and scientifically inaccurate. But when approached carefully, the observation has clinical value. In some cases, addressing the emotional context of illness, not as a replacement for medical treatment but alongside it, appears to affect outcomes. The body does not make sharp distinctions between physical and psychological threats. Both activate the same stress systems. Both draw on the same finite pool of energy and immune resources. A change in one domain can, through shared pathways, create ripple effects in the other. There is a particular category of unexplained recovery that involves autoimmune conditions. In autoimmune disease, the immune system attacks the body's own tissues. It mistakes self for non-self. Conditions like multiple sclerosis, rheumatoid arthritis, lupus, and type 1 diabetes all involve some form of this misdirected immune response. What makes autoimmune recovery cases interesting is that they require the immune system to do two things: stop attacking healthy tissue and, in many cases, repair the damage it caused. Both of these processes are poorly understood. In some cases of multiple sclerosis, spontaneous remyelination has been observed. This means that the myelin sheath, the insulating layer around nerve fibers that MS destroys, has partially regenerated. Oligodendrocytes, the cells that produce myelin in the central nervous system, can in principle produce new myelin. But in most MS patients, this process is limited and the disease overwhelms it. In the rare cases where significant remyelination occurs, researchers have found increased activity of oligodendrocyte precursor cells and reduced local inflammation. Something shifted the balance. The destruction slowed or stopped, and the repair cells were able to catch up. What triggered that shift? In most documented cases, no clear cause has been identified. The body's capacity for repair is real. The question is what locks it, and what, on rare occasions, sets it free. Wound healing provides a useful parallel for thinking about unexplained recovery, because it is a process we understand relatively well. When the skin is cut, a cascade of events begins. Blood clots form. Inflammatory cells arrive to clean the wound and fight infection. Fibroblasts begin producing collagen to rebuild the tissue. New blood vessels grow into the area. Epithelial cells migrate across the surface to close the gap. This process involves dozens of cell types, hundreds of molecular signals, and precise coordination across time. And yet, it happens reliably, automatically, without any conscious effort from the person who was cut. The body already knows how to repair itself. It does it constantly, at scales both large and small. What unexplained recovery cases suggest is that, under certain conditions, repair processes may operate at a scale or speed that exceeds what our models predict. Perhaps the question is not how can the body heal itself? The body heals itself continuously. The question is what limits the scale of that healing, and can those limits ever shift? It is a question that sits at the boundary between what is known and what is suspected, and it is worth sitting with quietly, without rushing toward an answer. The concept of hormesis offers one possible framework for understanding some unexplained recoveries. Hormesis is the observation that a small dose of a stressor can provoke a stronger than expected repair response in a biological system. Exercise is a common example. During exercise, muscles experience micro-damage, oxidative stress, and energy depletion. These are, in isolation, harmful, but the body's response to these small harms is disproportionately strong. It repairs the damage and overshoots, making the muscles stronger, the cardiovascular system more efficient, and the metabolic processes more resilient. Cold exposure, caloric restriction, and certain plant toxins, like the polyphenols in vegetables, may work through similar mechanisms. The mild stress triggers repair pathways that improve overall function. In the context of unexplained recovery, hormesis may explain why some patients improved after acute infections or high fevers. The physiological stress of the infection, while dangerous, may have triggered an immune response that exceeded what was needed to fight the infection alone. And that excess capacity, that overshoot, may have spilled over into anti-tumor activity. This is speculative, but it aligns with what we know about how biological systems respond to challenge. They do not merely return to baseline, they often exceed it. The body, it seems, sometimes heals best when it is given a reason to fight. Spontaneous regression has been reported in nearly every type of cancer, but certain patterns appear more frequently than others. One such pattern involves regression following incomplete surgical removal of a tumor. In these cases, a surgeon removes part of a tumor, but is unable to remove all of it due to its location or spread. The expectation is that the remaining tumor will continue to grow, but in a small number of cases, the residual tumor shrinks and sometimes disappears. One hypothesis is that surgery itself triggers an immune response. The act of cutting into the tumor releases tumor antigens into the bloodstream and surrounding tissue. These antigens are molecular fragments from the tumor cells. When the immune system encounters them in this new context, outside the immunosuppressive microenvironment of the intact tumor, it may mount a response that targets the remaining tumor cells. This is similar in principle to how cancer vaccines work. They expose the immune system to tumor-specific molecules in a context designed to provoke an immune response. Incomplete surgery may accidentally achieve something analogous. The evidence for this mechanism is indirect and based on case observations rather than controlled trials, but it offers a plausible biological explanation for a pattern that has been noticed by surgeons for over a century. The body sometimes needs a glimpse of the enemy before it can organize a response, and sometimes the surgeon's blade provides that glimpse without intending to. Fever therapy was a recognized medical treatment in the early 20th century, before antibiotics became widely available. Physicians deliberately induced fevers in patients with certain conditions, particularly neurosyphilis, an infection of the brain caused by the syphilis bacterium. The Austrian psychiatrist Julius Wagner-Jauregg won the Nobel Prize in Medicine in 1927 for developing malaria therapy for neurosyphilis. He injected patients with malaria parasites, inducing repeated bouts of high fever. After several fever cycles, the patients were treated with quinine to clear the malaria. Many showed significant improvement in their neurological symptoms. The mechanism, understood in retrospect, involves the heat sensitivity of the Treponema pallidum bacterium, the organism that causes syphilis. High fever creates an environment inhospitable to the pathogen, but the fever also activates immune cells and increases their motility and effectiveness. Wagner-Jauregg's treatment was abandoned once penicillin became available for syphilis, but it remains one of the clearest historical examples of deliberately manipulating the body's internal environment to fight a disease that medicine could not otherwise treat. It was crude. It was dangerous. Patients sometimes died from the malaria, but it worked in enough cases to win the highest prize in medicine, and it demonstrated, decades before modern immunology, that the body's own responses can be redirected against its own diseases. The idea is old. The mechanisms are becoming clearer. The abscopal effect is one of the more puzzling observations in radiation oncology. It occurs when localized radiation treatment of one tumor causes shrinkage of a distant, untreated tumor in the same patient. The term abscopal comes from the Latin ob, away from, and scopus, target. The effect was first described in 1953, but it remained rare and poorly understood for decades. The leading explanation involves the immune system. When radiation kills tumor cells at the treated site, it releases their internal contents, including tumor-specific antigens, into the surrounding tissue. Dendritic cells pick up these antigens and present them to T cells in the lymph nodes. The activated T cells then circulate through the body, seeking out cells that display the same antigens. When they encounter the untreated tumor at a distant site, they attack it. In effect, the radiation functions as an unintentional vaccine. It teaches the immune system what the tumor looks like, and the immune system does the rest. The abscopal effect has become more common, though still uncommon, since the introduction of checkpoint inhibitor immunotherapy. When the immune brakes are released, and the immune system is simultaneously shown what to target, the combination sometimes produces responses at sites far from the original treatment. It is a reminder that the body's immune system operates systemically. A response triggered in one location can have consequences throughout the entire organism. Healing, like illness, does not always stay where it starts. There is a small but growing body of research on what some investigators call radical remission. This term, popularized by researcher Kelly Turner, refers to cases of cancer recovery that occur either without conventional treatment or after conventional treatment has failed. Turner's approach was ethnographic. She interviewed over 100 people who had experienced radical remissions and identified 9 common factors that these survivors described. The factors included radically changing diet, taking control of one's health, following intuition, using herbs and supplements, increasing positive emotions, releasing suppressed emotions, embracing social support, deepening spiritual connection, and having a strong reason for living. This list is not a treatment protocol. It is a pattern observed through interviews. The factors are subjective, overlapping, and impossible to test in a controlled trial. Critics have rightly pointed out the survivor bias. These are people who recovered and then described what they did. Thousands of others may have done the same things and not recovered. But the overlap with what we know about psychoneuroimmunology is notable. Many of the factors Turner identified correspond to known biological pathways: social support, emotional release, stress reduction, dietary changes that affect inflammation. These are not mystical concepts. They are processes with identified mechanisms. The question is not whether these factors can affect biology. The evidence says they can. The question is whether they can affect biology enough, in the right circumstances, to produce the outcomes described. And that question remains genuinely open. The gut microbiome has emerged in recent years as a major player in immune regulation. The human intestinal tract contains trillions of bacteria, comprising hundreds of different species. These organisms are not passive passengers. They actively communicate with the immune system and influence its development and behavior. Roughly 70% of the body's immune cells reside in the gut-associated lymphoid tissue. The microbiome trains these cells. It helps them distinguish between harmless substances and genuine threats. It influences the balance between pro-inflammatory and anti-inflammatory immune responses. Disruptions to the microbiome from antibiotics, diet changes, chronic stress, or illness have been linked to altered immune function, increased inflammation and greater susceptibility to autoimmune conditions and infections. In the context of cancer immunotherapy, the microbiome has proven to be a significant predictor of treatment response. Patients with certain microbial profiles respond better to checkpoint inhibitor therapy. In some cases, transferring gut bacteria from responding patients to non-responding patients via fecal microbiota transplant has improved treatment outcomes. This means that the composition of bacteria in the gut, which is influenced by diet, stress, environment, and lifestyle, can determine how effectively the immune system fights cancer. The implications are broad and still being mapped, but the general principle is clear. The body does not fight disease alone. It fights in partnership with trillions of organisms that most people never think about. A community so small it is invisible, and so important it may determine outcomes that matter more than almost anything else. Epigenetics is the study of how gene expression changes without alterations to the DNA sequence itself. Genes can be switched on or off, turned up or turned down, by chemical modifications to the DNA or to the proteins that DNA wraps around. What makes epigenetics relevant to unexplained recovery is that these modifications are responsive to the environment. Stress, diet, toxin exposure, social conditions, and exercise all influence epigenetic markers, and some of these markers affect immune function directly. Studies have found that chronic stress produces epigenetic changes that increase the expression of inflammatory genes and decrease the expression of genes involved in antiviral defense. Meditation and stress reduction, conversely, have been associated with epigenetic shifts that favor reduced inflammation and improved immune surveillance. This means that life experience does not merely affect how you feel. It affects which of your genes are active, and those changes in gene expression can persist for weeks, months, or longer. In principle, a significant change in life circumstances, a resolution of chronic stress, a shift in diet or social environment could produce epigenetic changes that alter immune function. Not overnight, but gradually through the slow mechanisms of gene regulation. The body is not fixed. It is a living document, constantly being edited by the conditions in which it finds itself. The thymus is a small organ located behind the breastbone. In childhood, it is active and large, producing T cells and training them to distinguish self from non-self. By adulthood, it begins to shrink, a process called thymic involution. By middle age, much of the thymus has been replaced by fatty tissue. This decline is one reason the immune system weakens with age. Fewer new T cells are produced. The immune repertoire becomes less diverse. The body relies increasingly on memory T cells from past encounters rather than producing new ones for novel threats. But the thymus does not disappear entirely. Even in older adults, small pockets of functional thymic tissue remain, and there is growing interest in whether thymic function can be partially restored. In a small clinical trial published in 2019, researchers used a combination of growth hormone, DHEA, and metformin to attempt thymic regeneration in older men. Imaging showed regrowth of thymic tissue, and blood tests showed an increase in new T cell production. The participants also showed a reversal of epigenetic age markers. The study was small and preliminary, but it demonstrated that the thymus retains some capacity for regeneration, even in adulthood. In the context of unexplained recovery, this is a reminder that the immune system is not static. It can be changed by hormones, by nutrition, by the chemical environment of the body. And if it can be changed, then the range of possible immune responses is wider than any snapshot suggests. The circadian rhythm, the body's internal 24-hour clock, governs far more than sleep and wakefulness. It regulates hormone secretion, body temperature, metabolism, and immune function. Nearly every cell in the body contains molecular clock machinery that synchronizes its activity with the external cycle of day and night. Immune function follows circadian patterns. The number of circulating immune cells rises and falls over the course of the day. Inflammatory responses are stronger at certain times. The production of cortisol, which modulates immune activity, follows its own circadian curve. Disruption of the circadian rhythm through shift work, chronic jet lag, or irregular sleep schedules has been associated with impaired immune function, increased inflammation, and higher rates of cancer. The World Health Organization classified shift work involving circadian disruption as a probable carcinogen in 2007. This tells us that timing matters. The immune system does not operate at the same level around the clock. It has periods of heightened vigilance and periods of rest. When this rhythm is respected, immune function is optimized. When it is chronically disrupted, the system degrades. In the quiet hours of the night while you rest, the immune system is active in its own way, repairing, patrolling, adjusting. The body heals on a schedule, and the schedule is written in light and dark. Telomeres are protective caps at the ends of chromosomes, often compared to the plastic tips on shoelaces that prevent fraying. Each time a cell divides, its telomeres shorten slightly. When they become too short, the cell can no longer divide and enters a state called senescence, or it dies. Telomere length has been studied as a marker of biological aging. People with shorter telomeres tend to have higher rates of age-related diseases. Chronic stress, poor sleep, smoking, and sedentary lifestyles are associated with accelerated telomere shortening. An enzyme called telomerase can rebuild telomeres, but it is active mainly in stem cells, reproductive cells, and, problematically, in most cancer cells, which use it to achieve a kind of immortality. In non-cancerous cells, telomerase activity can be influenced by lifestyle factors. A study by Elizabeth Blackburn, who won the Nobel Prize for her telomere research, and Dean Ornish found that a program of diet, exercise, stress management, and social support increased telomerase activity in immune cells over a 3-month period. This does not mean that lifestyle changes can reverse aging, but it suggests that the cellular machinery of repair and maintenance is sensitive to the conditions in which it operates. A body under chronic stress ages faster at the molecular level. A body given resources for repair may slow that process. Every chromosome in your body carries a small clock at each end, and the speed of that clock is not entirely fixed. Psychosomatic medicine has a long and complicated history. For much of the 20th century, psychosomatic was used dismissively, implying that a patient's symptoms were imaginary. This damaged the field's credibility and caused real harm to patients who were told their suffering was all in their head. But the underlying science has matured. The modern understanding of psychosomatic processes is grounded in the same neuroscience and immunology we have been discussing. The brain regulates bodily functions through the nervous system and the endocrine system. Mental states alter these regulatory systems. Therefore, mental states can produce physical symptoms and potentially influence physical healing. The term now preferred by many researchers is mind-body medicine, though even this is slightly misleading. It implies that mind and body are separate entities that interact. In reality, they are aspects of a single integrated system. The brain is a physical organ. Thoughts are electrochemical events. Emotions are patterns of neural and hormonal activity. When a person's emotional state changes, their body changes, not metaphorically, chemically, cellularly, measurably. The extent of that change and whether it can reach the threshold needed to alter the course of a disease is the question at the center of everything we have been discussing. It is a question that science has not finished answering, but it is no longer a question that science ignores. The placebo response varies between individuals, and researchers have begun to identify some of the factors that predict who will respond most strongly. Genetic variation plays a role. The COMT gene, which influences dopamine metabolism, has been linked to placebo responsiveness. People with certain COMT variants show stronger placebo responses in pain and depression studies. Personality traits also matter. People who score higher on measures of optimism, openness to experience, and empathy tend to show larger placebo responses. Anxiety can either increase or decrease the response, depending on the context and the condition being studied. The therapeutic relationship is among the strongest predictors. A warm, empathetic practitioner who expresses confidence in the treatment produces larger placebo effects than a cold or indifferent one, even when the treatment is identical. This last finding is particularly important. It means that the quality of the human interaction in a medical setting, the eye contact, the tone of voice, the time spent listening, is not merely a nicety. It is a biologically active component of treatment. It changes outcomes. It changes the chemistry inside the patient's body. In a world that increasingly automates and accelerates medical care, this finding deserves more attention than it typically receives. The oldest medicine is attention, and it still works. Conditioning is another mechanism through which the body can learn to produce physiological responses to inert stimuli. The classic example comes from an experiment with immunosuppression. In the 1970s, the psychologist Robert Adur and the immunologist Nicholas Cohen conducted an experiment with rats. They paired saccharin-flavored water, a taste stimulus, with injections of cyclophosphamide, an immunosuppressive drug. After repeated pairings, they gave the rats saccharin water alone, without the drug. The rats' immune systems were suppressed anyway. Their bodies had learned to associate the taste with immunosuppression and produce the biological response without the chemical cause. This finding was foundational for psychoneuroimmunology. It demonstrated, for the first time, that the immune system could be conditioned in the same way that Pavlov's dogs were conditioned to salivate at the sound of a bell. Subsequent studies have confirmed that conditioning can influence immune function in humans as well, though the effects are smaller and less consistent. The implication is that the body learns from its environment. It forms associations, and those associations can drive real physiological responses, including immune responses, based on context and expectation rather than direct chemical stimulation. The body is a student. It pays attention to patterns, and it responds to what it has been taught to expect. There is an aspect of unexplained recovery that is rarely discussed in scientific literature, but appears repeatedly in patient narratives: the experience of meaning. Many patients who have recovered from serious illness describe a moment, sometimes sudden, sometimes gradual, when they felt a deep sense of purpose or clarity about their lives. This is difficult to study. Meaning is not a molecule. It is not a pathway. It cannot be measured with a blood test or visualized on a scan. But the psychological literature on meaning-making and health suggests that it may have biological correlates. Viktor Frankl, the psychiatrist who survived the Nazi concentration camps, observed that prisoners who maintained a sense of meaning and purpose survived at higher rates than those who lost it. He did not frame this in immunological terms, but subsequent research has connected purpose in life to lower levels of inflammatory markers, better immune function, and reduced mortality from cardiovascular disease. A study published in JAMA Internal Medicine found that people who reported a strong sense of purpose in life had a lower risk of death from any cause over a follow-up period of several years. The association held after controlling for age, sex, income, education, depression, and chronic disease. Meaning does not heal the body in any direct, traceable way that science has identified, but it appears to be associated with a physiological state that supports healing. A body inhabited by a mind with purpose may allocate its resources differently than one without. This is not a prescription. It is an observation, and it sits at the edge of what science can currently measure. The immune system has memory. This is one of its most remarkable properties. After encountering a pathogen and mounting a successful response, the adaptive immune system retains a population of memory cells, memory B cells and memory T cells. These cells persist for years, sometimes decades, ready to respond rapidly if the same pathogen is encountered again. This is the principle behind vaccination. The vaccine introduces a harmless version of a pathogen, allowing the immune system to learn and remember it without the risk of disease. If the real pathogen arrives later, the memory cells respond quickly and effectively. In the context of cancer, immune memory is more complicated. If the immune system successfully eliminates a population of tumor cells, it may retain memory cells that recognize those tumor-specific antigens. This could, in principle, provide lasting protection against recurrence. Some researchers believe that this is what happens in the most durable cases of cancer regression. The immune system does not merely destroy the tumor, it remembers it, and it continues to patrol for cells carrying the same molecular signatures, destroying any that emerge. This would explain why some unexplained remissions last for decades without recurrence. The body has not just cleared the threat, it has learned from it. Memory is protection, in the immune system as in life. Angiogenesis is the process by which new blood vessels form. Tumors depend on angiogenesis for growth. Beyond a certain size, a tumor cannot survive on diffusion alone. It needs a blood supply. It achieves this by releasing chemical signals, particularly vascular endothelial growth factor, VEGF, that stimulate nearby blood vessels to sprout new branches toward the tumor. If this process is blocked, the tumor is starved. This is the principle behind anti-angiogenic cancer drugs. But the body also has natural anti-angiogenic molecules. Compounds like thrombospondin 1 and endostatin work to limit blood vessel growth and maintain the balance between vessel formation and vessel pruning. In some cases of unexplained tumor regression, researchers have hypothesized that a shift in the local balance between pro-angiogenic and anti-angiogenic signals may have cut off the tumor's blood supply. Without new vessels, the tumor could not grow. Without growth, it became vulnerable to immune clearance. This is consistent with the broader theme. The body contains both disease-promoting and disease-fighting mechanisms. They exist in a balance, and shifts in that balance, even small ones, can have large consequences. A tumor that was growing can stop growing, not because of a drug, because the chemistry around it changed. And sometimes that change is enough. Sleep, though we are not discussing it as a topic, plays a direct role in immune function. During sleep, the body produces and releases cytokines, proteins that direct immune cell communication and activity. Certain cytokines increase during sleep, particularly those involved in fighting infection and inflammation. Studies have shown that sleep deprivation, even for a single night, reduces the number of circulating NK cells and impairs T cell function. Chronic sleep restriction is associated with increased susceptibility to infection, slower wound healing, and reduced response to vaccination. A study from the University of California found that people who slept fewer than 6 hours per night were over 4 times more likely to develop a cold after being exposed to the rhinovirus, compared to those who slept more than 7 hours. The immune system does not rest when the body rests. It works differently. The quiet hours are when some of its most important maintenance and surveillance functions peak. This basic fact that the body's defense system operates most effectively when the mind is still and the body is quiet is relevant to everything we have discussed. Stress disrupts sleep. Loneliness disrupts sleep. Chronic pain disrupts sleep. And each of these disruptions degrades the immune system's capacity. Rest is not passive. It is an active biological state in which the body concentrates its resources on repair and defense. You are, right now, in the early stages of that process, and your body is already adjusting to meet it. The concept of allostatic load describes the cumulative wear and tear on the body from chronic stress. The term was introduced by Bruce McEwen and refers to the physiological cost of repeated activation of the stress response. Every time the body mobilizes for a threat, real or perceived, it activates the HPA axis, raises cortisol, increases heart rate, redirects blood flow, and suppresses non-essential functions like digestion and immune repair. In the short term, this is adaptive. In the long term, it is destructive. High allostatic load has been linked to cardiovascular disease, metabolic syndrome, cognitive decline, and impaired immune function. It is measured by a combination of biomarkers including cortisol, blood pressure, waist-to-hip ratio, cholesterol, glycated hemoglobin, and inflammatory markers. What is interesting in the context of unexplained recovery is the possibility that a sudden or significant reduction in allostatic load through a major life change, a resolution of chronic conflict, or a shift in psychological state could free up biological resources that were previously devoted to managing stress. Think of it this way. If the body has been running an emergency program for years, constantly diverting energy to the stress response, and then the emergency ends, the resources that were tied up in that response become available. The immune system receives more support. Repair processes accelerate. The internal environment shifts from alarm to restoration. This is not a proven explanation for any specific case, but it is a framework that aligns with what we know about how the body allocates its finite resources. When the weight lifts, the body sometimes remembers what it was capable of before the weight arrived. Intercessory prayer has been studied in randomized controlled trials with mixed and largely negative results. The most well-known study, the STEP trial study of the therapeutic effects of intercessory prayer, published in 2006, found no significant benefit from intercessory prayer in patients recovering from cardiac surgery. In fact, patients who knew they were being prayed for showed a slightly higher rate of complications, possibly due to performance anxiety. But other, smaller studies have reported modest positive effects. The inconsistency of results makes it difficult to draw firm conclusions, and the mechanism, if one exists, remains entirely unknown. What is worth noting is not the question of whether prayer works in a clinical sense, but what the study of prayer reveals about the relationship between social connection and health. Many forms of prayer involve community, ritual, shared intention, and a sense of being supported. These elements, independent of any supernatural mechanism, activate the parasympathetic nervous system, promote oxytocin release, and reduce stress. If prayer does have health effects in some contexts, the most parsimonious explanation is that those effects come through the same psychoneuroimmunological pathways we have already discussed, not from divine intervention, but from the biological consequences of connection, calm, and directed attention. The body does not distinguish between sacred and secular sources of comfort. It responds to the chemistry they produce. Awe is an emotion that has only recently received sustained scientific attention. Dasher Keltner and his colleagues at the University of California, Berkeley, have studied awe extensively and found that it has distinctive physiological effects. When people experience awe, whether from nature, music, art, or witnessing extraordinary human kindness, they show reduced levels of pro-inflammatory cytokines, particularly IL-6. They report feeling smaller and more connected to something larger than themselves. Their attention shifts outward, away from self-focused concerns. The mechanism appears to involve a shift in autonomic nervous system balance. Awe activates the vagus nerve, which reduces sympathetic arousal and promotes the parasympathetic state associated with rest, digestion, and immune function. In the context of healing, awe is interesting because it is one of the few emotions that simultaneously reduces stress, increases social connection, and promotes a sense of meaning. These are three of the factors most consistently associated with better health outcomes in the psychoneuroimmunological literature. Many accounts of unexplained recovery include descriptions of experiences that sound like awe, moments of overwhelming clarity, encounters with nature or beauty, a sudden perception of the vastness of existence. Whether awe contributes directly to healing is unknown, but it shifts the body in directions that favor it. And it costs nothing, it asks only for attention. The emerging field of psychedelic-assisted therapy has reopened questions about the relationship between consciousness, emotional transformation, and physical health. Psilocybin, the active compound in certain mushrooms, has shown promise in clinical trials for depression, anxiety, and end-of-life distress in cancer patients. What is notable for our discussion is not the psychiatric effects, but the immune-adjacent observations. Patients in psilocybin trials frequently describe experiences of profound emotional release, dissolution of ego, and a sense of interconnection. Follow-up studies show lasting reductions in anxiety and depression, often after a single dose. If these psychological shifts are genuine and lasting, they would be expected to affect the same stress-immune pathways we have been tracing. Lower anxiety means lower cortisol. Greater sense of connection means higher oxytocin and vagal tone. Emotional release means reduced allostatic load. One study on ibogaine, a psychedelic compound, found reductions in PTSD symptoms that persisted for months after a single treatment. Participants also reported improved physical health, though this was self-reported and not independently verified. The research is young, and the claims are larger than the evidence currently supports. But the principle that a deep shift in consciousness can produce lasting changes in the body's stress and immune chemistry is consistent with everything we have discussed. The mind is not separate from the body. It is the body experienced from the inside. And when it shifts profoundly, everything connected to it shifts as well. There is one more phenomenon worth noting as we approach the end of this long, quiet journey. It is called the Lazarus syndrome, named after the biblical figure raised from the dead. It refers to documented cases where patients declared clinically dead have spontaneously regained vital signs. The medical literature contains dozens of such cases. Cardiopulmonary resuscitation is stopped. The patient is pronounced dead. Minutes later, sometimes longer, the heart begins beating again. Blood pressure returns. The patient, in some cases, recovers fully. The mechanism is not well understood. One hypothesis involves delayed recovery from hyperinflation of the lungs during CPR. When chest compressions stop, the pressure in the chest cavity normalizes, allowing blood to return to the heart. Another hypothesis involves delayed action of medications administered during the resuscitation attempt. But in some cases, no adequate medical explanation has been identified. The body simply restarted. These cases are rare. They are not common enough to change clinical practice, but they remind us that the boundary between life and death is not a clean line. It is a zone, a transition, and within that zone, the body sometimes does things we did not anticipate. We have moved through a long collection of observations tonight. Spontaneous regressions documented by careful researchers, immune cells patrolling in silence, fevers that triggered unexpected recoveries, toxins injected by a determined surgeon in 1890s New York, the quiet records of Lourdes filtered through decades of scrutiny, placebos that changed brain chemistry without any active ingredient, a sham surgery that healed real knees. We trace the pathways from the brain to the immune system, through the vagus nerve, through cortisol and oxytocin, through GABA and serotonin and the trillions of bacteria in the gut. We saw how loneliness weakens the body and how connection strengthens it, how meaning and purpose correlate with markers of health, how the body keeps a running score of the stress it carries, and how, when that score drops, resources become available that were previously locked away. None of this tells us that unexplained recovery is common. It is not. It remains rare, unpredictable, and impossible to prescribe. No responsible physician would tell a patient to replace treatment with meditation and hope. But the science tells us something worth holding. The body is not a machine that either works or fails. It is a living system, responsive to its environment in ways that reach deeper than any single treatment or drug. The chemistry of emotion feeds into the chemistry of immunity. The quality of sleep affects the patrol routes of NK cells. The warmth of a hand on a shoulder changes the concentration of molecules in the blood. We do not fully understand how these systems interact during the rare events we have been discussing, but we understand that they interact. The pathways are mapped. The molecules are identified. The connections are real. And perhaps that is enough for tonight. The body is doing its quiet work right now. Cells are dividing. Damaged tissue is being repaired. Immune cells are moving through the blood, checking, signaling, remembering. You do not need to direct any of this. It happens on its own. It has been happening since before you were born, and it will continue through the night. The questions we explored tonight do not need answers right now. They can wait. They have been waiting for centuries. They will still be there in the morning. For now, the body rests. The mind settles. The chemistry of calm begins its slow, familiar work. Stars turn overhead, though you cannot see them. The earth moves through space at a speed you cannot feel. And somewhere inside you, in the quiet dark of your own biology, the oldest systems in your body are doing what they have always done. Repairing, protecting, renewing. Let them work. Let the night be long and still. And let the questions rest beside you, quiet as breath, until the morning comes.